everybody. I am going to review some things with you. And I'm going to teach you about the autonomic nervous system and how we can treat it. I think you guys were here last week. Who wasn't here for my autonomic lecture last quarter? Cool, awesome, sweet. So it's going to be new for some of you, review for others, and hopefully we can keep diving in, digging deeper, and figuring out how do I treat a dysautonomia? How do I identify a dysautonomia? How do I know if I adjust my patient that their nervous system can handle what I do? Okay, so we're going to review, then we're going to go over Ben is going to go over the autonomic anatomy and how the brainstem works. And then I'll jump back up and go over tests and treatments and like how to figure it out. And then I think this is just around the idea of trauma-informed care and how to navigate expressing to your patients that might be a little more sensitive or it might be a little on edge, what's wrong with them, and how we're going to move forward in treating it. Okay, so what does a neuron need to survive? Don't make me point. Yeah, go. Glucose. Okay, what else? Oxygen. What else? Appropriate stimulation may be the most important thing to us as neurologists because we say perfect practice makes perfect. We haven't taught you cerebellum yet, but when we teach cerebellum, you'll find that not only just does repetition make you better, but you have to do that repetition the exact same way every single time to really formulate that plasticity in the brain. Okay. Does the cortex control movement ipsilateral or contralateral? Contralateral. Okay. Now, let's take that a little step further. Does the cortex shunt blood ipsilaterally or contralaterally? Ipsilaterally. Good, guys. Good. Listening. All right, somebody tell me the loop. Not an officer. Chris, you got the loop. What? Yeah, you got it. You got it.
Cerebellum, meso-thalamocortical-pontus.
Bingo. Okay, ready? Everybody together? Cerebellum, cerebellar. Okay, now, what are the four main lobes of the brain that we talked about? Well, maybe we didn't talk about it. What are the four main lobes? Frontal. Okay, frontal. Parietal. Occipital. Temporal. Good. Good job, guys. All right, so here's a little review of each lobe, and we're going to go over quickly the tests, and then I have a breakout soon where we're going to integrate these tests. Right, which basically just wanted to tell you something really quick. So, we've got our frontal lobe. It's executive function. Its main job is inhibition. A good brain is a brain that inhibits. Good. So, we have our pincer test. This is testing frontal lobe, prefrontal motor cortex function. We can do it bilaterally and together. This is a good way to see, okay, now can I do both sides and add in a little bit of dual testing. Then we can look at gait. Someone walking, and then say I want you to overload the frontal lobe because the frontal lobe is supposed to handle multiple tasks at once and inhibit multiple tasks. So I'm going to walk, and then maybe I'm going to ask you to pincer and count down from 100 by sevens. I can't even start to do that. So, right there, you probably have a little bit of overspill and see my gait be challenged or the pincer test be challenged. Okay, then we've got our parietal lobe. So, Dr. Esposito explained this to me and I really loved it. We talk about the brain having our where stream of consciousness, our where stream of consciousness and our why stream of consciousness. So we have our parietal lobe coming from the occipital lobe. We get information through the occipital lobe over the parietal lobe telling us where it is and then integrating in the frontal lobe. So that's our where stream, everything to do with proprioception, mapping, periproprioception, the space around me. And then some tests that we can do is point localization, so I can have my patients hold over their eye, hold open their arms, close their eyes, touch here, and have the patient try and touch. Actually, can I get someone to come up here? Por favor. And then, all right. So, the legs, close your eyes, come here and touch that point. Okay, here. Okay. And then, if you want to out.
Is that there?
Yeah, good job. So if your patient, say I'm holding here and your patient can't do it, so it miss, okay? Then you can add a little stimulus. Maybe I'm going to vibrate and move it around, give them a little more information where that point is. Then we can do graphesthesia, which is drawing a number or a, do you have that pen too? A number or a letter or something on, can I see it? Your hand. So it's going to be, so I'm going to close the eyes, I'm going to draw this letter.
Okay.
It was upside down, so I'm going to draw it towards the patient so that they understand.
Hey. There we go.
Okay, then stay here for me. We have our what or our why stream of consciousness through our temporal lobes. Temporal lobes have everything to do with telling us what things are. So when you look, I think the best way to describe temporal lobe is when you look at hallucination and psychedelics, that's inhibiting the frontal lobe's inhibition of the temporal lobe, meaning the temporal lobe gets to run free and create and think and see whatever it wants to create and think and see. So it has everything to do with recognition of faces and remembering names and identification. Typically you can say I wanted to do a temporal activation. I'm going to show Ben a picture of a turtle and ask him to name what that animal is, or maybe the color associated with the turtle, some higher function associated with seeing, identifying what that image is. You can do sound. Sound is definitely recognized in the temporal lobe. So I'm going to have my patient close his eyes, and I'm going to rub my fingers together. Can you hear this?
Mm-hmm.
Okay, I want you to tell me when you can't hear it.
It's gone.
Nice. So you can measure that on both sides, see if the distance is equidistant, is it lower on one side, to kind of give you maybe a little bit of a hemisphere. I typically find that to be like the same. And then you can, I'm going to go more like identification if I want to test the temporal lobe than necessarily sound, because you start integrating premotor gait, and you can have issue there instead of your temporal lobe. Okay, and lastly, our occipital lobe has everything to do with just processing information. So you're going to get color through the temporal or occipital lobe. When you have occipital lobe lesion or headache, that's where you get really colorful auras. And then you can do confrontation testing, which is, this is kind of a test between the occipital lobe and it's like a little bit of the mix of the temporal lobe, because I'm asking him to identify, one, if he's seeing it, and two, if it's moving or if it's not moving. That's going to be a little bit of a temporal activation as well, moving or not moving. The occipital lobe is going to register that finger being there. So I'm going to have him close one eye, and I'm going to come down at every 8 fields of vision and ask him, is it moving or not moving?
Not moving.
And when he can see it soonest.
I can see it. Not moving.
Okay?
Not moving.
Moving.
It was?
Yeah.
Not moving. Oh, no, it was. Oh! Just that was moving.
Okay, so hold on to those. I can throw those back up when we go to do the breakout. But now I want to jump into, I'm going to let me just explain this really fast, because then you're going to dive more into it, right? Okay. So we've looked at the cortex a little bit. And now we're going to start looking at the brainstem. The brainstem has everything to do with our autonomic function. And Ben's going to jump deeper into those nuclei and those centers that are in our brainstem. So we've got our thalamus, which is our relay center, grand central station. All information comes through the thalamus and leaves the thalamus. We have our midbrain. This has highly to do with dopamine production and gathering all stimulus. It activates our sympathetic nervous system, keeps us alive. If your midbrain is not functioning and you have a hypotonic sympathetic nervous system, send your patient to the ER, because you need that sympathetic nervous system to survive. Okay? Then we've got our pons, our pontine. So we have cranial nerves, before I trip myself up, 3 through 6 in there. And then we've got 7, 8, 9, 10 in the medulla. Did I say that right? Nope. We've got 5, 6, 7, 8. There we go. 5 through 8 in the pons. And we've got 9 through 12 in the medulla. Thank you, Ben. That's all I'm going to give you right now. Think cranial nerves in the brainstem, pons medulla. Okay. So, something that I love to do when I teach, I'm not lecture. You've seen, you've been here before, done it with me. This is a technique that I learned from Dr. Jerome Loa. He is an excellent doctor at treating traumatized patients, or maybe patients with high anxiety or other mental disorders. So it's called sensory recall. And what you do is you basically are attempting to isolate the senses. You're going to have that patient identify each sense one at a time to bring attention to and activation to this brainstem, which houses our respiratory centers, our cardiovascular centers, and everything in between, our vagus nerve. So if I activate this part of my brainstem, this being the ponto medullary reticular formation, or PMRF, which inhibits all midbrain activity, so our sympathetic centers. So if you activate the PMRF, you're going to bring the sympathetic center. So we're going to try it. We're going to zen out, take a deep breath, and then get back. So I want everybody to close their eyes. Okay. So first, I like to start with the sense that is probably the least stimulating. So I'm going to have you think about 5 things in the room that you can smell. Maybe it is the smell of your cologne, or perfume, or the person next to you's body odor. Maybe it's the smell of the room, or the air. So once you try to identify 5 things, maybe being your clothes or something else, I want you to identify 5 things that you can taste. So whether that be the taste of your own lips, maybe you can grab your shirt and taste your shirt, or the taste of your skin, maybe the taste of the chair. I wouldn't suggest. Okay? And then from there, I want you to think about 5 things that you can hear. Whether it's my voice, or maybe it's the flow of the air conditioner, or the voices down the hallway. Pinpoint those sounds. All the while taking nice, deep breaths. Okay. And now, I want you to think about 5 things that you can feel. I can feel sweat on my palms. I can feel the chair underneath me, the ground beneath my feet. I can feel the warmth of my clothing, my hat on my head, and my hands on my legs. Okay, now we're going to move into vision. So there's 3 forms of vision. Not everybody has this first one. But I want you to picture something that doesn't exist. Whether that is a pink elephant, or a flying alligator, maybe a spotted zebra. Dive into that creativity, that childlike state of imagination. Okay. Now, I want you to try and remember 5 things that you remember seeing in this room. Whether it's the pattern of the carpet, an outlet on the wall, maybe where there's a vent or a light bulb, maybe the projector screen, maybe where I'm sitting. And now, deep breath in, and when you exhale, take your time opening your How you feel?
Pretty good.
Pretty good. Pretty zen, huh? So this is a super awesome technique that you can use with high-strung patients at the beginning of your session to get their body ready, to be attentive, to learn to grow plastic size. Get those respiratory centers working, get that oxygen to the brain so they can plasticize your pathways. Good job, guys. All right, Benjamin is going to teach us some anatomy now that we're all filled out and ready to learn. And I'll see you soon.
All right.
You got something?
Thanks, Machi. Oh, that actually felt wonderful. I needed that. All right. What is the? Sorry, I have to get the little laser pointer. It's just like I like to point to too many things. It's a problem. Yeah. So before we begin, y'all remember the loop, right? One of the things that actually took me a little while to figure out is midbrain and meso are the same thing. So if we talk about meso or talk about midbrain, same guy. Nothing different there. One of the first things we're looking at here, all this guy, so this is your midbrain. So picture you took off the top of my head and you're looking straight down into it. So this is the front part of my face and then this would be my back. Cool? Just kind of get you oriented in space. So that first one up there, this nuclei here, so that one is important with with Parkinson's. So the thing itself is your substantia nigra. Actually, side note again, who is that Dr. Carrick's seminar? A lot of us. I don't know how many times I heard like rostral portion of the nigra and all these kinds of things. That's the guy he's talking about. It took me a little while to get there, but it's happening. So the reason that I think that this one's really important is its relationship with the data. So that in and of itself is involved with movement a lot. So your motor activities, a lot of that is with basic ganglia. And that one in particular, its relationship with Parkinson's is the way that it will present. So some of the common terms of that are like cogwheel rigidity, or it's a shuffling or festinating gait, and then you usually have a resting tremor. So with that, the way it helps you remember this structure's importance in movement is what Parkinson's patients look like when they move. So I can have like a little bit of a resting tremor, they're usually pretty slumped forward, and then they get like a little, just a little shuffling gait like that. If you watch them turn around, it's just like this. It's real slow. So that's like the really extreme portion of if you were to have some dysfunction related to your substantia nigra, that's the very far end of it. So does that mean if I'm having issues with that structure that I'm going to be like this? Not necessarily. But that's kind of the big idea, is just to think of what the far version is, and then with your own clinical skills, kind of fill in the middle parts. Does that make sense? Cool. Our next one up there, our red nucleus, which matches the color up there, which makes my brain really happy. It is related into, again, some of our motor functions. So in particular, there's one of the tracts that comes out of here is known as your rubrospinal tract. Red, rubro, I think rubro Latin. I think this one is. Yeah. So those are related to each other. That path in particular goes to some of the proximal muscles in your shoulder. So you can think of arm swing with that. So like Banaji talked about, let's say I'm walking and I'm not really getting, it's hard to make myself not do it, have a good arm swing on my right side. One of the things that he mentioned is, let's do some dual tasking. Let's get that frontal lobe activated, and maybe I start counting down from 100s by 7s, and I get good arm swing. Maybe I need that extra frontal lobe activation. Or if we do the dual tasking, even with pincer or the counting, there's no change. Does it guarantee me my problem sits right there? Not necessarily. But the idea is, if you don't see it with dual tasking, there are other things that it can be. Does that make sense?
Sure.
Cool. Next one, medial geniculate nucleus. That is a hearing one. So for every word that Banachi said earlier that I'm currently saying, that guy's putting in some work. Or if you don't want to listen to the words I say, you can kind of turn that guy off, which is totally fine. It's good either way. But that's one of the main ones in hearing. So we'll see this relationship with some of our other structures of hearing that we'll talk about later. So that one, hearing, is the big one on that one. And then this next one, oculomotor and trochlear, those two right in there. We spend a whole week on just eye movements. Is that next week? 2 weeks? 2 weeks. 2 weeks, yeah. So in 2 weeks' time, we will spend a lot of time just on the eye movements. So I won't dive into it too much, but the main idea is this. In the midbrain, that's where we have cranial nerve 3 and 4. So that is trochlear being your number 3, oculomotor being number 3, trochlear being number 4. So just as a little fun pop quiz. So we have 5 out of the 6 eye movements covered by those 2 cranial nerves. What's one that's not from those? What is it? Hey, what movement does that movement, Carson? Hey, look, who said Carson's a smart guy? Yes. So the one that's not up there is our abduction of the eyes, taking it out. So that's our lateral rectus from our abducens nerve, which we'll see in a little bit on our next slide. And then the last one we have our superior and inferior colliculus. They're not actually like on top of each other, but it's a 2D picture, so I can't really see the difference in 2 structures in that way, so we just have to put those together. So specifically, your superior colliculus, you want to think more on the vision side, and then your inferior colliculus, you want to think sound. The main things that those are used in is finding out where is that sound, where is that light coming from. Light is usually what I say when I say vision. Just for this example, it makes it a little easier that way. So if we were sitting in this room and all of a sudden there was a huge bright light that goes out there, I'm like, oh, what was that? Siri, I know what I'm talking about, I think. All right. Yeah, so there's a huge light when we look over there to find out where that light is. That is your superior colliculus. Or all of a sudden the speaker blows up. And we all look, what was that loud noise? That's your inferior colliculus. So the reason that those are important, I kind of think of it as more of like a survival mechanism or like a reflex. If I'm just standing here and all of a sudden there's this object that's in my peripheral vision, I'm like, oh, what is that? Is it a baseball coming towards my face, or is it a beach ball? Is this something that is danger to me, or am I good? Is it just gonna like bounce off my head and fly? So that's what this path is involved in, is figuring out where that stimulus is, whether it be vision, whether it be sound, bringing our head towards that area, head and eyes together. Everybody good so far? Any questions? Cool. So, that exact pathway with our superior colliculus is known as the tectospinal tract. So, this one in particular, like we said, so tectospinal was with our superior colliculus. So, if I were to have that bright light and I look at where the bright light is, this path is involved in the coordination of the stimulus we receive, knowing where that stimulus is, move my head and neck to that stimulus. Sorry, head, neck, and eyes to where that is. So that's what this is kind of showing. So you have this blue part up here. So now, this is what I told you. This is the front part of us now. This is the back. So we take from our superior colliculus and we go down through, eventually out through the spinal cord here on our motor portion of it. Now, the really important thing about this that Vinasci mentioned is this area right here. Right? So it's showing in particular like the pons and the medulla separated, but the way that we look at the path that this tract takes is with the pons and medulla together. That's the PMRF, your pontomedullary reticular formation. So this tract in particular, tectospinal, along with a lot of your other descending tracts, so coming from our cortex down through, they pass through this pontomedullary reticular formation, which you can kind of see they kind of highlighted one of the nuclei here, the pons and the medulla. But it's not just like 2 specific dots, right? It's all this kind of interconnected web in there. And a lot of those tracts that go from cortex down through go through that area. So one of the things that you guys might have experienced before, that's actually happened to me, is, let's say I got a Fox exam coming up, and we all know how those are. Yeah. So I'm getting super stressed and I'm getting really worried, and what if my neck starts to hurt a little bit? So the reason that that can kind of play into both of these together is we know that our PMRF is part of the parasympathetic division. If I'm in that really, really heightened sympathetic state and I'm not modulating this area correctly, well, we're not going to get proper movement with our muscles in the neck. And what if that manifests itself as pain in my neck because of the dysfunction of its muscles, right? So even if you get neck pain, is that an auto adjustment? I mean, that's a good starting place, but that's not the only answer all the time. And along those same kind of lines with dysfunction in that area, has anybody felt like just super jumpy some days? Where you just like, there's like stuff going on in the background and you're like looking at everything, you just like can't focus? Does anybody else do that?
Oh yeah.
Yeah, I'm there all the time. So that again is we are not properly modulating PMRF. That's the best word I can go with right now. So we're getting all that extra stimulus, and we're always going at a heightened state before it. Does that make sense? Cool. So now, like Meenakshi talked about a little bit, we're into our pons and our medulla. Pons being that guy, medulla being this guy. And one of the things we want to look at is how can we affect those areas? And the main way we're looking at it is through the cranial nerves. So the main one we want to start off with is trigeminal. So one of the ways you can do it is your muscles of mastication if you want to chew. Or you kind of break the face up into thirds. So you have a third here, a third here, and a third here. Those are innervated on that sensory portion by your trigeminal nerve. So that's the way you can think of those areas. That's trigeminal. Okay? So when we think that, we're thinking pons with that. And then we've already mentioned abducens, so our eyes going out. Abducens nerve, lateral rectus, that's that pathway. We kind of talked about that a little bit. And then we got facial. So with our facial, one of the phrases used with that is the ranges of emotion. So you're happy, you're sad, or like the puffing, whatever. So all of those movements of the muscles in your face, that one's more with your facial nerve. The next one, which we talked about briefly, is your vestibulocochlear. We talked about the sound portion of it, that's your cochlea part. And later this quarter, we'll get to the balance side. So that's the vestibular part of it. So those kind of work together. And again, we spend a whole week just on that portion of it. So we'll dive into more detail that way, but with vestibulocochlear, it's hearing and sound. Sorry. Ooh, those are the same thing. Hearing and balance. Woo, great. So you might be thinking to yourself, wait a second, we were just talking about the mediogeniculate nucleus. That was in the midbrain. Isn't hearing in the midbrain? Not necessarily. It's that same idea, again, that it's just not a bunch of different structures that we draw a line to directly all the time. Everybody's favorite phrase always applies to neurons that wire together, fire together. Again, the same thing. We have to get the heat, the sound to come in from our ears, which goes along our vestibulocochlear nerve, and ultimately back up all the way through to our mediogeniculate nucleus and beyond. So again, it's not that we have to follow a specific path all the time. Hearing is not just one specific area. It's all very interconnected. Does that make sense? Cool. And then we get into our medulla. So the main one is glossopharyngeal. Well, not the main one. One of them is your glossopharyngeal. The main thing I tend to think of that one is swallowing. It's like the muscles in the way back of your throat. Those are involved with that cranial nerve. We got our, now see this one, you're probably thinking to yourself that I don't know how to spell. And 9 times out of 10, you'd probably be right. But no, it's the vagus nerve. And here's why. Yeah, here's why. So when I think of cranial nerve 10, there's just one thing that comes to my mind. I don't know if this is just me. It's geese. It's just the goose. And here's one reason why. What do geese and, like, let's say, ducks and chicken have in common? Ducks and chicken taste delicious. And what is cranial nerve 10 involved in? Digestion. Big time your GI tract, right? So that's really big part of it. That's not all. There's one more part that I think is really important. So when I'm standing outside, which I do every now and again, and I see a goose flying towards me, I get really anxious. Like, I'm nervous, because what if they poop on me? Then my day's ruined. So I get really nervous, and my heart starts to race. But here's the thing. Vagus, I misspoke. The vagus nerve has a pathway involved with decreasing our heart rate to let me chill out and know that the goose is not pooping on me today. So, I think it's a typo, but who's going to forget what the vagus does now? Nobody.
And like geese kind of go all over the place. Like
That's
the
what I was
goose
thinking.
kind of-
They do,
fly everywhere.
it's all over. Yeah, exactly. That was a lot of fun. Okay, our next one, which is less exciting than the vagus nerve, is your spinal accessory. Big 2 ones on that, SCM innervation and your trap innervation. So a lot of your head lateral flexion, your head rotation, those are the main guys with that one. And then our last one, our hypoglossal, your tongue. Dig out your tongue, yep, that's hypoglossal. So the whole point of going through all those really fun things is just to look at the different ways we can look at different parts of the brain. So it doesn't, like I mentioned, it doesn't mean that every single thing we do is separate and distinct, and they're not related at all. Because to a degree they kind of are. But the idea is, if we want to look at different ways to look at the ponds, there's a lot of things we can do. Same way for the medulla. There's a series of things we can do to paint an overall picture, not just a tiny little thing. Does that make sense? Mm-hmm. Any questions so far? Okay, so now we're going to break out. So, like I mentioned a little bit, we want to do some PML, our F activation. So there's a couple things that I had mentioned when we were covering that previous slide, but I want you guys to get creative. If you have other ways that you want to activate specific part of either the pons or the medulla, I can leave this slide up or the other one, whichever y'all prefer. I want you guys to do that. If it's something that you came up with, you need your creative ideas, you will remember it more, and it's more applicable to what you want to do. So, partner up, we'll break out, all the officers will be around you. If you have questions for us, just let us know.
Come up with 3 therapies to share.
Yeah, and we will call on people.
Bye, Thompson Club.
Does anybody want to share one of the things they can do?
There's no want, you must.
Yes.
One of these 3 do.
What you got?
Testing geometry.
Okay, nice. I like that one. Anything in particular you're looking at with that?
Respiratory.
Nice, that's a good one. Yep, cool. Has anybody done a VO2 max test before? How do they feel? Awful. They genuinely, they're terrible. You like literally run to your aerobic one. They are not fun. But if you want to look at a true relationship between like how your breathing is and your heart rate and like what percentage of gas you're taking out and all that kind of stuff.
Do a peak or a max?
Say it again.
Do a peak or a max?
I think I do max. Yeah, it's not fun.
That's rough.
Yeah, those are good. Okay, that was good. I like that. One more. We're going to be doing them on. Hmm?
Does it sound like this is good or
Hey, you know what? Classic. I love that. Yep. People on watch, we'll count that sound implementation. Wonderful. Okay, so now we're going to take a little step back and kind of look at autonomic nervous system as a whole. So the main thing that we want to think about with autonomics is our fuel delivery and waste disposal. Wow, fuel delivery. It's in all caps, it's bold. Is it one of the 3 things a neuron needs to survive? It is indeed. Wow, isn't that really important? And then the other one, along with our fuel, which you know is carried throughout our body by the blood, is the other thing that our blood carries. Oxygen, yes. Number 2 thing the neuron needs to survive. So it's kind of cool that within the autonomic nervous system itself, it houses 2 of the 3 most important things we need for a neuron to survive. I think that's pretty cool. I know we talked about that it's important, you know, like Bonacci said, if you're having all these, what did you say that it was, Bonacci? Like they're hypotonic, sympathetic, how did you describe it? Can you describe it?
I said hypotonic.
Hypotonic.
Yeah.
Okay, yeah. So again, that means we're not getting either of those 2. Sorry, yeah, fuel or oxygen. Lots of problems. The other thing, like I mentioned, so it's in relation to your blood vessels. So whether it's more parasympathetic or sympathetic, do we have dilation or constriction of specific arteries? How are we directing blood depends on what system is activated a little bit more at the time period, which we'll dive into that a little bit later, but just keep those in your thoughts. I mentioned the 2 divisions are sympathetic and parasympathetic. So then this is a really, really important slide. You want to keep track of how your patients are doing, not just with their progress overall, but in the moment while you're taking care of them, you want to be aware of that. So one of the main things that we can use to help monitor autonomics is a pulse ox. Does everybody know what that is? Sorry, does anybody not know what a pulse ox is? Cool, yep, little thing, clip on your fingers. The 2 main valves that you can look at are your heart rate and then your SpO2, which is your oxygen saturation percentage. So again, our heart rate, which we know is related to our blood, so that's fuel delivery. And then oxygen obviously is with our oxygen, so those are related. So those are a really easy way to see how your patients are doing. So let's say that I'm doing some, like vestibular therapy, so I'm doing this guy. So I'm looking at my thumb, and I'm turning my head, and you can just have a pulse ox on my finger. And And let's say it starts to spike. My heart rate is just going up and up and up and up. All right, let's take a break. That's the way you can use it, is if they're starting to get to the point of their threshold to receive the stimulus and you go past it, then you're not getting that neuroplasticity that you want. So you want to make sure that you are close enough to that threshold that the stimulus is positive for them. You don't want to overload that. And that's where the key point of appropriate stimulation applies. Where we're monitoring to see how our patients are doing. If we provide too much, that's something we want to know. Yes, go ahead.
Would you continue to do that therapy, but in small doses or increments?
Absolutely you could. So if we know for sure that like it's vestibular related or eye related and I need to do that therapy, let's say I can only handle this right here. If that's all I can handle, then you stop. Yeah, absolutely. You want to take it in smaller portions, see what they can handle. You don't have to go, I have to do this for 10 minutes a day, twice a day, you know, like whatever. No, you want to do what your patients can handle. And if you're able to increase it, then go with it. You want to continue as your patient progresses, progress your care with that. Good point. Any other questions? So this exact thing kind of happened to me in clinic last quarter. So this was a very big wake-up call for me because I did not monitor the autonomics of my patient as well that I should have. So the patient that I was seeing, they were looking to get upper cervical care, in particular toggle, which I love to do. For those who don't know, I think upper cervical is pretty cool. So my patient had never been toggle before, like, all right, you know what, let's do it. Let's see how it goes, because I'm really curious to see how they would respond to it. So we got the x-ray set, did the analysis, everything was great. Got the listing, did a whole pattern analysis, or thermography, leg check, whatever, all that good stuff. It got to the time to adjust, and I did my little setup, did my toggle, and to me it felt good. It was like, yep, it was a good thoracic table drop, all the good things. Did a leg check, yep, balanced at the end, that's great. And they were saying that they felt a little different. And since they had never been toggled before, it was kind of with my, if I change hats, my chiropractic philosophy hat, yeah, it's an upper cervical adjustment. The body's going to change. It's a very powerful input to the body. Let's see what happens. Which, as we move forward, in the next couple of days, they got checked out by another student. And that student had found that they had that same atlas listing that I found, but it was like, how do I describe it? It wasn't fully corrected, but it wasn't fully out. Does that make sense? So it was like half fixed, half not fixed. So they did that atlas correction to finish it, and then they started to feel a little better. So they mentioned that to me, and I was like, okay, so what if I just did my toggle a little harder? Because I try to be pretty light with it because it doesn't always feel the greatest if you get like a piezo form, like driving right in there, not necessarily the greatest place to be. So okay, we'll turn up the tension a little bit on the headpiece. And I did my toggle just like I usually do. And they again felt terrible. And this time around, they mentioned how sweaty their palms were. No kidding, they could have dumped their hands in water and handed them to me. It was like, yeah, I really should have looked at that. Isn't that wild? It was like I'm not kidding. Like it was very, very wet palms. And they had mentioned that they think that their midbrain is a little bit sensitive, and I was like, okay, I should have been injecting that as we go through it. But that was a really big eye-opener to me because it really hit home the point that not every patient is going to receive the main thing that I do. Like I kind of view myself as an upper cervical doc when I get out in the field. That's kind of like my vision of myself. But I had a patient while I'm here that did not respond well to that adjustment. Now, does that mean that upper cervical is bad? No, but that was too much stimulation for them. It's one of those where I should have been keeping track how they were before and how they did after. That just wasn't something that I did. They're still alive. They're great. They didn't fall off and die, promise. But it was a really big eye-opener that you should keep track of that. It is actually a really important thing. So I thought that story was interesting. It was just like, I think the real life stuff like is a little easier to like grasp and stuff, or like the goofy stories, like the vagus nerve, which I still think is really funny. Yeah, so like that's why like that whole story is basically this bottom statement right here. Autonomic state is the best indicator of brain integrity and functionality. So when we were post-adjustment, even if the leg check looked good and the thermography scan was different, which is typical of a post-adjustment with a toggle, their sympathetics were not in a good state. So we could tell that they were not having that integrity and functionality with their autonomic state. We could tell that that was not what they needed. Any questions on that? All right, so we talked about this kind of a little bit, but this is like one of those big summary slides. It's got some good text on there. So the two divisions we've highlighted are sympathetic over on this side, parasympathetic on this side. So with the sympathetic, which we'll see, sorry, go ahead, yes.
Just jumping back to the situation in the clinic, do you think that if you would toggle a little harder, or toggle again, I don't know if you can do that they wouldn't have had the autonomic response then?
Oh, I was going to talk about that. I didn't. Thank you.
Yeah.
So I thought about that. It might have been too much stimulus, and then I was starting to think of like the position that they were in. Is that the issue? Because they hadn't been taught before. Is laying on that side specifically, is that not the ideal scenario? Can they not handle the stimulus coming to this side of their body specifically? Or has anybody you been adjusted on a drop table before? Yeah, you know that like the cervical head piece, that's loud. Is it that when I did the toggle, that loud stimulus was too much for them? Because they've been adjusted a few other ways, even on their Atlas. I don't think those with the drop. And I think they still respond fine.
Okay.
So it kind of varies, like, is there, like, in that moment, what things could be going on? And that's the hard part, is like, there's a lot of different pieces to that puzzle, trying to put that together. So would I have done the third one? That probably wouldn't have been a good idea. Because then my patient feels terrible if it doesn't go well again. I just don't want to be in that scenario. Cool. Question. Anything else? Sweet. Okay. Yes. So sympathetic, like I was talking about with my patient. One of the things that we will use often is with our sympathetic nervous system, we'll use the letters IML kind of often. So it's like interchangeable terms. So your IML, your intermediolateral cell column, all that it really does is describe where the thing is, which I'll show you a picture of it a little bit, and it'll make a little bit more sense. In the sympathetic nervous system, we think of the IML being from T1 to L2 as the main area that's at. And also along in that same area, we have our sympathetic chain ganglion or paravertebral ganglion, again, two kind of interchangeable terms, which we'll get to here. This is important how it's like a short cranial long post, and that's just like that's one of those things that you'll see on like boards and stuff, and they'll just like ask you that question, like which part of the nervous system has the long ganglion, and it's just like it makes more sense to actually look at the pictures, but it's kind of annoying to just like sit there and memorize that sometimes. And this right here, fight, flight, or freeze, that's like some of the easy, like just like what's the word? Thank you. It's one of those where it's like sympathetic, fight or flight, parasympathetic, rest in the chest. It's just like one of those kind of things that you can use to jog your memory if you get a little lost. So speaking of that guy, parasympathetic. I was going to say that. Yes, this is also called thoracolumbar. So if you notice, it's from T1 to L2. T for thorax, thoracic. L for lumbar. And then this one, our parasympathetic, is your craniosacral. So we think the cranium, right, PMRF is upstairs in the cranial vault. And then we have our S2 through 4. S for sacral. You guys are so smart, you already know this stuff. Rest and digest, like I mentioned. Yeah. This we'll see those in a picture. I really like pictures, I think it's easy. That's the guy I'm talking about, the IML right there. So this picture in particular, just to get you guys oriented. So you cut me in half, like, I don't know, here, so T something or other. And then you pull out so the spinal cord, as you look at it, there's only like a big circle around it. We just kind of pulled that stuff out. So that's your, like the white myelinated axons. We just remove those guys. Because all we care about is this cell body right there. So like I mentioned, that in particular structure, that IML, will be present from T1 to L2. So that's why it's important. Yeah, so there's just a few things on text up here. This was kind of tricky for me for a little bit. This homologous column was, yeah, sorry, go ahead.
Just the parasympathetic, it's craniosacral and it's brainstem, and it said IML S1, S2, S3, S4, something like that. Yeah.
Yes.
Does that mean that the intermediolateral cell column of the sacrum is part of this parasympathetics, and then it goes up to the thoracolumbar and turns into sympathetics?
Bingo. So that gets exactly what I was talking about. This homologous column of cell bodies, they run exactly like that, right? So you have meso, midbrain, PMRF, thoracic lateral horns, and also our sacrospinal cord. Okay, so you're just look, you and me, we're right there. So that lung is called the cell body. What that really means is they developed from the same thing from an embryological perspective. I'm not going to horrify anybody with some embryo, but bear with me. So whatever part of it is in the nervous system as we begin to develop and grow, it's from that same structure, so they get farther apart. So though it's kind of the same composition, the functions are different. So when we're in that, the craniosacral division of that structure, it's parasympathetic. When we're in that thoracolumbar, it's sympathetic. Does that help?
Yeah.
Cool. Wonderful. Yep, so we talked about this a little bit. It's a lot of horn cells, it's the gray matter. And there's some text on here, so if you guys want to keep that down, you can. Sometimes the text with arrows helps you, but like I said, I'm more of a picture guy. So if you want to take a picture of that, you're welcome to do so. While I'm doing that, we'll talk about this guy at the bottom right here, how it mediates sympathetic innervation in the entire body. So though we call it the thoracolumbar division, and we think that, do sympathetics only act here? Yes or no? No. So even though that's where the cell bodies are located, that does mean that we are limited to this area. So that's why, woohoo, my picture. It's not my picture, it's a picture. It's my picture. Yeah, it's technically Bonacci's picture, the better pen. So as we start over here, we have our IML, it's that little corner right there. And what we're looking at in this pathway, in this blue that I'm kind of tracing here, it goes in this direction. This is our efferent portion, anterior nerve roots and all those, rootlets and all those great things. And then we get to this guy right here. That's your sympathetic chain ganglion or paravertebral ganglion. And those run, like I said, the same length of where the IML goes. And the reason that we have these is so that we can have sympathetics, like I said, affect the entire body. So what we will see with these signals that come out this way, there's a few locations that they can go. This first one, down out kind of at the same level, and this is one of our prevertebral, one of those ganglion out this way to the visceral side. We can also have it kind of loop back if you follow it this way. It loops back around, goes down, again kind of at that same level along that next spot on it. Or it can go in here, go up to another level and do some synapsing, or it can go down to another level and synapse. So that is the main thing on that side is that sympathetic chain ganglia. The nerves come out into it, and then it goes to different levels all over the place. Everybody listening so far?
Yep.
Cool. So I also really like this picture in regards to thermography. So I know a lot of times I'll hear people talk about thermography, and they'll say that like, oh, there's a big red bar on like the right side of my T, and I have to adjust that time. Like there's heightened sympathetics there. Not necessarily. That's not really what you're looking at. With your thermography, in particular with your Titron, they are detecting infrared heat, and it's from your skin, blood vessels in your skin. It's reading that heat, and it's giving you that difference on either side. So it's kind of an indirect way to look at the sympathetics, but it's not a true assessment of it. It doesn't really give you, this is where I need to adjust, and this is the side. You can use thermography as an overall assessment of the body, if that's something you want to do. You don't have to. Can. But that's why this is looking at all of those together as a, what am I trying to say? It's not just at that level. You know what I'm saying? It can go to multiple places. It's not focused in on that one structure. Again, it's a network as well. Cool? Okay. And now we got our parasympathetic portion of that. So this one, you might be thinking that it's just at one level. But no. Those three dots right there can go from about here to like maybe down here. Because you know that our vagus nerve is super, super long. Sorry, that's really funny still. How it'll go all the way down. So that's that pre-ganglionic portion. It's super duper long. We're not really synapsing on those chain ganglia and going out. It's really long, it goes all the way down. Cool? Sweet. Any questions on any of that? Sweet. Now for the exciting part. Come on up, Bonacci.
All right. Thank you, Benjamin. We were very excited. I did give him some boring anatomy, but he also wanted it, so.
I did.
Yeah, he crushed it. Yeah. Okay, so I just want to review some simplistic differences between sympathetic and parasympathetic. You guys will hear about this forever in school, and people will still get it wrong in 11th quarter. So you guys will be the ones that will get it right in 11th quarter. So we've got on our parasympathetic side, we have pupil constriction, right? Because when we're sympathetic, we dilate our pupils to let more light in, more information into the brain so that we can survive better. If you look at different species of animals, they'll have maybe like reflective paneling around their eyes to get even more light into their eyes and they can see better in the dark. That would be cool to have. All right, stimulates saliva. So parasympathetic, we think rest and digest. Slows our heart rate down, constricts the bronchi, stimulates peristalsis and the secretion of acid and different digestive enzymes, stimulates bile production, and contracts the bladder. It's really interesting. Yeah, well, we're going to go with that. So then I'll explain it over here. So sympathetic, we have our dilated pupil, inhibits saliva. It's like when you're running, you get kind of a dry mouth. Increases the heart rate, it dilates the bronchi so that we can get more air. Inhibits peristalsis and secretion so you stop digesting. Because when you're running from a tiger, you don't necessarily need to digest the meal you eat, but you might feel a little sick if you just ate, because you then stop digesting. We've got glycogen to glucose, so our livers are going to start converting to give our body more energy to use to create movement. Then we've got adrenaline and noradrenaline, all from our solar plexus. So we've got those catecholamines, those stress hormones that are going to upregulate blood flow and muscle tone so that we'll move more and survive. And then inhibits bladder contraction. So technically, like, yes, when you're running, you're not going to think, oh, I really have to go to the bathroom right now. But the sympathetics do tend to open sphincters, release sphincters. So you might piss yourself and then start running, and then not think about peeing, right? Because your body wants to get anything it doesn't need to worry about in a survival mode out, all those toxins, because those are toxins, so it wants to release toxins, and then get into a state where it can thrive the most. Coolio? Who needs a little 7th inning stretch? Okay, let's get up, walk around the room, and then come back, and I'll get out. All right. Looks like we lost half the room, but we'll see. Painful views. All right. Sympathetic nervous system. Hey, can you stop talking, please?
Can you not yell at me?
All right, ready? Sympathetic nervous system. Dilates pupils, increased heart rate and blood pressure. Vasoconstricts of larger arteries. Vasodilation of arterioles. Increased sweating, bronchodilation, increased gastric motility. We kind of just went over all of these. Stimulation of the adrenal, medulla, and adrenal cortex. Not to be mistaken with the medulla oblongata. Okay, so who? Yeah.
What about the medulla is stimulated? Because I know that, is it the catecholamines are released from the medulla?
Bingo. What catecholamines are released from the medulla?
Norepinephrine.
I think so. Is that right?
There's
Yeah.
no way he knows, right or wrong.
Other catecholamines are there.
There are. Dopamine is considered a catecholamine. And there's a couple others, like really minute ones. But then what's the cortex?
Cortex, salt, sugar, sex, aldosterone.
Yeah, aldosterone. Nice. Good job.
Thanks, Doctor.
There we
Yeah,
go.
he said that.
That was years ago. And I already took my board, so okay. Alright, here's good stuff. PMRF. So I just went out to the hallway and called my friend up and I was like, what's the difference between a PMRF lesion and a midbrain lesion? Because it took me a long time to really figure out. So we're going to look at PMRF and 4 functions. Does anybody know the 4 functions of the pontomedullary reticular formation? Or one of them?
They know all these things.
You know, I'll take one of them. Go.
Inhibition of pain.
Okay.
Inhibition of anterior muscles above T6,
Good.
posterior below T6.
Yep.
Inhibition of inhibitory interneurons.
Yes.
Inhibition of something else.
Nine. You got it. So inhibition of pain, inhibition of interneurons, based off of this right here. Got it.
Sorry, can we just briefly, what's the thing about lesion?
Oh, sure. Okay, so in neurology, we operate under a physiological, a functional lesion model, a physiological lesion model. So, whereas aggressive chiropractic is under an orthopedic model. So if I trip and hit my knee gets displaced because it was hit out of place. In neurology, under a physiological lesion model, I hit my knee and my muscle tone, my brain jiggied my muscle tone. It wasn't whatever I hit my knee on that was my knee out of place, it was my muscle tone that was my knee out of place. And so we say lesion whenever there's like a physiological block. So maybe there's not enough flow of that neuron to that site. Because when you get to neurodiagnosis, you're going to start talking about hard lesions, like the cord is cut. So that's why you can do a Romberg's with the feet standing apart, close your eyes, and fall over, because they have no afference from their vestibular system, from their dorsal columns. Now, when we talk about lesions in functional neurology, we're just talking about a reduction in that afference, or a reduction in that efference, in that signal. Okay? Cool. What?
You could have just said dysfunction.
Sorry, did I ever explain that?
No,
It's okay if I ever explain.
that was good for me.
He's pretty smart.
Yeah, okay, that was good.
Just saying.
So anyways, so if you have a lesion or reduce a dysfunction in the PMRF, what might you experience just based on these right here? Because I never thought about it.
Tension and anterior.
Bingo. So if I have inhibition of the flexors above T6, maybe I'll have excitation of the flexors above T6. Maybe instead of inhibition of the posterior T6, I'll have excitation of posterior below T6. Does that make sense? Kelly?
Oh, sorry, my face looks like it's been one of those days.
I thought you were really trying to process that.
No, I was channeling, I was having a not so very good moment where I was like in my own head and I was like,
Yeah. All right. So then, if your PMRF is lesion, maybe you have too much pain. Maybe if your PMRF is lesion, you're not properly inhibiting the IML, which you could get a little bit of midbrain lesion spillover. But maybe you're breathing really fast, or maybe you're jittery and shaky, or maybe you're releasing too much adrenaline, or maybe what?
Then PMR, this is probably a dumb question. Can PMR lesions be acute and chronic?
Okay, just remember I'm supposed to repeat the questions for the back room. Can PMRF lesions be acute and chronic?
Yes.
Sure. Yeah.
Okay.
I think, yeah. I think typically dysautonomias are a little more chronic. It takes some time to get there, but I'm sure there's some wildly traumatic events that could happen that are going to set off your PMRF. Thoughts?
Yeah, like a concussion doesn't always have to be chronic. It can be healed in 4 weeks and that could be a PMRF issue, like your autonomics kind of show.
Yeah. I'm convinced that just about everybody's been concussed, and that's why we all have issues. Neuroinflammation.
Also too, if you think about like the change in your muscle tone after, say you're in a state of stress and your anterior muscles are going to start going like this, and you're going like this, and your arms start to fold over like that, if you're chronically like that, and that's going to build up that like muscle tone, that memory of like holding that position. But say you do one set at the gym, like that's a bad example.
No, that's
But
a great
it-
example.
Yeah, but like once you're holding that muscular tone for a while, like your body's gonna remember that. Keep sending that afferentation back up to your brain, so it's how quick you can recognize it. Like with concussions, for example, our brain is so eager to heal right after an injury. So if you recognize you're in a stress state, the quicker you address it, the more of an acute issue it's going to be. But the less quickly you address it, no matter what where the lesion is, the longer that afferentation is going to come back up, and probably the more difficult it is to reverse that.
Could you work yourself into a PMRF lesion? Like, let's say you deliberately flex your anterior muscles of T6.
Yep.
Would it eventually cause a PMRF lesion?
Yeah, because if you're flexing your anterior, you're going to inhibit your femur because it does the opposite of that. So you'll see a therapy. You can have someone come down here. Dr. Alice does this therapy all the time. I love doing it on my patients, and it's literally extending the flexors manually, opening up that shoulder and extending, and do that, and it feels nice. Like, and if you just whack them in the gaze stave in the shoulder, like you're gonna really upregulate the femur. So you can take it both ways. Yeah, good thinking. That's great. Okay, so here I modulates and inhibits all descending tracts primarily IML from the midbrain. So therefore that signals to the sympathetic. So that's why when I see, let's say when I get poked with my pen, I'm like, oh! Like, it's because my paramedic is modulating that sensory. Because that, when I touch my skin, I mean, that mechanoreceptor is being activated. Now, my brain tells me how much it's being activated with a series of equations and modulations. Cool? So, we already said this, neurons not wired together, fire together. So how do we activate the MRF?
Activate any of the granulars 5 through 12.
Yeah, 5 to 12. Or we can look at our cardiovascular centers, our respiratory centers. Those are also going to modulate. Just as like we do the shoulder thing, we can help our patient breathe. We can do meditation. We can do sensory recall. Those types of activities that are going to play along with that. Okay, 9 to 10 rule. This is confusing. I'll try to make it simple. So 90% of cortical input stays ipsilateral. That means only 10% of cortical output goes to the contralateral side for movement. Only 10% of our cortical output goes to movement. That's it. 10% goes to movement. The rest of the cortical output all goes to regulating our autonomic nervous system. I can't move my arm if I don't get blood to my extenders, if I don't get blood to my muscles. I can't move this finger if I don't get blood there. So that's basically how it's up. What's your name?
James.
James, right.
So like, say you move your arm, the ipsilateral side is regulating the blood flow to that. At the same time, your contralateral is like the movement of it.
Yep. So that means that every time we activate our cortex, we're getting bilateral output. But mainly our cortex is activating the same side of our body. Well, we always think, oh, the cortex activates the other side of the body because of movement. And we use a lot of movement in functional neurology. But the reality is 90% of this cortical output stays ipsilateral. 90% of that, 90, so 81% goes to the PMRF. 10% of this goes bilaterally to the midbrain to stimulate dopamine production to keep the midbrain stimulated intact sympathetically. Cool? Does that make sense? Does it not make sense? It doesn't. Ask your question.
I guess this is really dumb. Like cortical outputs. I guess I'm just
Stuck on that word?
Yeah, you're stuck on
Okay. If my brain sends a signal, that's cortical output. So any efferent information.
So that wasn't my question. It's okay.
No, it's not a question.
It's not a dumb question.
That's a fancy word, cortical output.
So like, cortical output is like the peripheral of the brain? Right?
Yeah, so I think
So any lobe?
yeah, lobes.
Peripheral. As
Yeah.
opposed to like center.
Right. So our brain is made up of our lobes and our brainstem and our insular cortex. But then we say the cortex is the lobes. And we'll say brainstem versus cortex. The brainstem and the cortex make up the brain.
So I thought that cortex, the lobes had like a cortex and a medulla, each lobe.
I don't think so. The lobes have
So
like
the
an
lobes
outer
are cortex.
they have like superficial and deep layers to them. But
when you talk about cortex, I mean that lobe is the cortex.
yeah. So
It's
frontal
confusing
front.
because renal, when you learn renal anatomy, when you start getting a little medulla and
Right.
the cortex and whatever, but
So,
Just click back to it. So,
it was this one.
It was
just
hard.
like in the-
Okay.
It was like,
I think I'm good.
Yeah, I'm going. Here we go.
Yeah.
So we've got like this outer layer, like gray matter, and then the white matter. But white matter is just dense cell bodies. That's really the difference we're seeing there. So it's just like, it's just going to be way more. Is that right? White matter is dense?
White matter is the.
It's the axons.
Right.
So really the cortex of the cortex is more dense than the inside. But basically the inside of a cortex of a lobe is just all circuitry, it's all wires. Sorry, I always get that backwards. Probably got that question wrong backwards. Okay. Guys, it doesn't matter all that much. Just think, the cortex shunts your blood ipsilaterally. That's all you need to know. And if you remember that, it'll take you so far in this life. And one day, if you're ever teaching this, you can learn about it. I'm serious. Like, just know that if I want to upregulate the PMRF on the right side of my body, what cortex do I want to stimulate?
Right.
The right. That's it. You got it. That's your therapy. Bingo? That's how I'm just gonna get rid of this slide. That's how I'm gonna say it. Okay, look here. Right somatic goes into the right cerebellum, to the contralateral cortex, into the ipsilateral PMRF, down to the soma, and gets bilaterally routed to the ion. That's your little pathway. Done. Okay. So, how do we test the PMRF? Everything. Everything tests the PMRF, especially vitals. Increased sensation, so you're going to look at like pinwheel, vibration, light touch. People, typically, if people struggle with sensory information, if they're always overstimulated, if they don't like being touched, they're pretty dysautonomic. And typically trauma leads to a dysautonomia. Increased pain is a note. Hypotonia, so decreased myotactic stretch reflexes, palatal-paresis, palpate muscle tone, so you want to feel for muscle tone. If there's decrease in muscle tone, it's going to be MRF lesion. You're going to look at posture, you're going to do muscle testing. All those can look at dysautonomia, neurological disorganization. Then all of your vitals, specifically blood pressure and heart rate, and increased sweating. So if I have a patient that is sensitive autonomically, I like to feel their hands. Are they sweaty? Are they cold? Are they warm? Are they dry? You can really gauge that quickly. Like before an adjustment, maybe they're like sweaty and I adjust them and they're dry. Or maybe vice versa, they're dry and adjust them and they're sweaty. Might not be so good for them because their brain can properly shunt their blood or regulate their hormones. Okay. Let's see if I got these right. Yeah. Yeah. Cool. Yes, I like this. Okay, so I got some midbrain lesions. Convergence insufficiency, suboccipital pain. So if I have issues converging my eyes, my head might try and do this, stress these suboccipitals. Sensitivity to light and sound, hyperreactive, hypermetrics, IML issues, hypertropia, esotropia, there's all those eyes. So a lot of eyes with the midbrain. I mean, we said the midbrain has how many movements for the eyes? 5 or 6. Great. Then PMRF lesions, we're looking at posture. Pupils is a little more midbrain. Increased heart rate, blood pressure, increased sweating, decreased gastric motility during fatigue. So the thing is though, no, I'm not going to say that. Okay. Okay, so here's some therapies. We're going to do some breakouts. We have 20 minutes left. I'm just going to show these to you and then you can try them. This is a great one, check in and go to the beach. So Dr. Lovell works with a lot of kids, especially with like ADHD, and their check-in is to do sun salutation too. And you just get these little kids doing this. It's like the best thing ever. So you check in. What's the first thing you do when you check in? And you're on vacation, you're checking into your hotel. What do before you go to the beach? You go to your room and you drop your baggage. So you leave everything there. What?
You don't pack, you throw your clothes away.
No, I go to the beach. I'm like,
You go.
change, let's go to the pool. So you drop everything that you have. And that's a great place to start, okay? I don't care what happened in your day before this. I don't care what happened 5 minutes before this fight or whatever. We're checking in right here, right now. Let's leave that behind us and let's grow. Let's learn. Let's heal. Okay, then we go to the beach. Beach is an acronym, obviously, for breathe, eye contact, attitude, attention, count, and hands. Who wants to come up here and try this with me? Kelly does. Okay, so first we have breath. Good breath. Okay? Then we have eye contact. So we want to maintain eye contact. You can't look away. Okay? Eyes on top. Then we have attitude and attention. A lot of kids are gonna get like really like, you know, they're gonna react, they're gonna be excited, or they're gonna get distracted, especially the kids with ADHD. They might be right here and they'll be like, the light. Did you hear that sound in the hallway? And they'll just get so, it's like, okay, you just have to be patient. Eye contact. Breath. Okay. And then we count. So we do hands and we count. So you have them lay hands on top. So we had this, I was shadowing a couple weeks ago, and we had this, we had these two siblings, these two sisters. One was gas, and the other was brakes. So one was this chronic CEO mentality. She just was a leader, right? A little 9-year-old just ready to like rule the world. And so we had come up with this idea for them that helped her still be empowered, while also being taught and learned. And so for her, our saying was, I, the doctor, am in control of the room, and you are in control of your body. If you struggle controlling your body, I will help you control your body. If you cannot control your body, I will control your body. And it set up this groundwork of, okay, well, I don't want somebody else to control my body, so I'm going to control my body. And it really motivates this leader, that's all gas and all go, to help regulate, control their body. Just a little ADHD, right? So for this was a really great exercise with her, because this helps initiate the brakes. So, hands on top gives the patient control. I'm just here to support. They're on top, they can pull away, right, they can do everything. So, eyes, okay, breath. You want to match my count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is actually a really great exercise for Kelly.
It's harder than it's
No, because Kelly, if she doesn't mind sharing, at the
Yeah.
end, you know Kelly, she's a gas.
Yeah.
She's always go, 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 and she needs some help with brakes sometimes. And so this really shows your patient that they can access those brakes, that they can control their facial tone, that they can maintain eye contact. And sometimes with kiddos, you have to give them a goal, like, okay, we're gonna count to 10. Or this time, we're gonna do 5 sets of going to the beach, and I want you to count to 10, and then the next time I want you to count as high as you can go. And so we were doing starfish with this little girl who's just on the ground doing cross crawl. So she's just here, she's going like this. And she was like, she could hardly get through 10 of them. Dr. Jones was like, okay, do 10. And she's like, and she just like wants to like do everything else. Then we did 4 sets of 10 and said, okay, how high do you think you can go? Give her a little challenge. She's like, 30. Okay? 250 reps later. And she got so hyperfixated, so focused on this exercise that she used all of her gas. And you can let your patient use all of their gas, because at the end after that, they're only going to have more breaks, and they're only going to have more ability to slow down and get all the energy out. What's up?
I will say when he says the words, but like I catch myself, like I come out hot and I'm like, 1. Like I'm so like ready to go. I'm like, when's he gonna say it? And then I start picking up on his tone, so then I start matching his tone. And then I notice myself subconsciously starting to match his facial expressions. So a lot of kids that have difficulty connecting with others too, it's gonna allow them to have that greater sense of connection, like, okay, like I'm starting to relate to what this person's feeling just by doing what they're doing. So that was.
That's great, yeah. I mean, your attitude and your attentiveness to your patients, like this is what I was just talking to Gio about this, like I was just like, Dr. Trump was trying to teach me professionalism, like that's like one of the things we don't quite learn in school. And it's like, this is what he taught me for this last time. I was sitting, because it's a very tiny room, and I'm sitting, and this is how I was sitting. And there's two, like the patient's parents were like an orthodontist and like some other big doctor, and they both have their own practices. And they're like, did he want to be there, or is it voluntary? Because I guess I was like so relaxed and so uninvolved because other neuro offices I've shadowed at, the doctors don't want me to interact. I just like was like sitting here like afraid. And so he's teaching me, okay, like proper posture. Like apparently if your back's on the back of the chair, that's not professional. Because these patients are spending $500 an hour to be here with Dr. Drum. So he wants me here. My posture's engaged, it's on, I'm interacting, and so he's just teaching me a lot about professionalism, and it's just some things that I've never like, oh no, man, come back, please, Mom. Cool. Why did I tell you that? I don't know. Attitude and attention, that matters. So everything that you do in an office really matters for treating patients. Okay. Sensory recall, we did that. Metronome, the brain really loves timing and complex movements and order. Summation of stimuli with the metronome can be strongly impulsive PMRF. So if you want to, I think I showed this last time. I'll show it to you. Does someone come land with one for me? I don't know what it's called, but it can really help.
You could lay on the table once.
Oh, whoa! Look at this. Imagine that. Let's go. Okay. Wow, that's awesome. It's nice to have it. Okay, so face up for me, please. Okay. So I have a metronome set at 60 BPM. It's nice, stable. I think the frequency of the earth is 58, so you can do that if you're trying to tap in there. So, steady beats. I'm going to have the patient close their eyes. And I'm going to, now, really depends on if your patient can handle touch, because some dysautonomic patients that have issues with sensory might not like being touched. But for patients that can handle it, it can be a really good integration of that dorsal column up into the cortex, up into the parietal lobe, back down to PMRF. Does that make sense? I touch them, sensory, parietal, PMRF. Okay? So, in no particular order or timing, you just walk around and do light touch. You can have them take off their socks. I had a friend that this was the only way to get rid of her migraines. Because her migraines would be stimulated from feeling outside of her body. And this can really help ground the patient and get them back inside of their body. Because all they're doing is breathing. And the only thing that doesn't stimulate the midbrain is meditation. So this almost induces a theta-like wave state with meditation with no visual stimulus. I'm kind of going fast, but okay. I don't know what to call that. Do that. Okay. Emotional entities around the dragon, breathing, tapping. If you're at my lecture last Thursday, I went into somatization of emotions. So the Chinese have mapped out through meridians and different order points emotions that are associated. I'll just teach you guys a quick help. You can take your hand, and there are 4 pulse points, 4 points in which meridians hand on your wrist. I don't have a picture of it, but I'll show you here. Boom, these 4 points. And you can take that and cover your emotional neurovascular centers like this. Move forward and take 5 deep breaths. And you can switch to the other 4 pulse points. If you're stressed out for an exam, it can be a quick little reset motion. Okay, and then obviously positive affirmations. I'm okay trusting my life can work out okay. I'm okay succeeding, I'm okay being successful. We call that surrounding the dragon. I'm okay being loved. That's good for me to be loved. That's healthy for me to be loved. I'm strong to be loved. Using words like that can really be powerful for someone, because at the end of the day, we just need to get ourselves to believe truth in what we're telling ourselves. If someone can't sleep, they wake up in the middle of the night at certain times, it can be correlated to emotion. So if you wake up every morning,
Could you go back? AK Club is actually shown those charts, so if you want to get on like a pre-order list, just let me know.
shameless plug. Absolutely shameless.
Well, I'm just saying, like, if we're gonna show like that.
No, yeah, it's great. And we have like this little wallet-sized.
Yeah, that's what I'm saying, we're doing.
Oh, you're doing it wallet-sized. Okay. So we do this maybe once a year to get these wallets.
I would say like once every 3 years, because I've been asking for decades, and then
Yeah.
we have to get like.
I'll pass it around, make sure I get that back. But it's a little wallet-sized NET chart. I use it all the time. It's super useful. It's helped me learn a lot. Get out of here. Okay, so if your patient keeps waking up at 1 a.m., it might be because they can't transition from gallbladder to liver. So typically, if they can't wake up at 1 a.m., you want to retrograde back to the last organ, gallbladder, resentment. Talk to them about maybe something in their life that they resent. If you don't do NET, still talk to them about it. Okay, visceral manipulation. This is huge. Activation of that vagus nerve. It's everywhere. Activated the goose, up to the pons, upregulate PMRF. Good to go. Dr. Ellis does classes on these. Maybe we can get him to do another one. And then POTS. All right. Do you want to teach POTS? I don't feel like.
Sure.
Yeah. Our lady, Madam President, everyone. Okay, just give me over you.
Okay, this is getting real rough, just broad. Possible orthostatic tachycardia syndrome.
Does anybody know what tachycardia means? Great.
Great job, everyone. Basically, a patient could be like, I can't go from lying to standing, or I can't go from lying to above 30 degrees because I feel like I'm going to pass out. So you can have a really wide range. You can have people that are like, I can stand for 15 minutes and I feel like I'm going to pass out. There's a girl in the clinic. I haven't taught you one thing about it yet before I tell you a story. Basically, the requirement for this is either a difference of 30 in your blood pressure or a difference in heart rate. Am I saying words correctly? I told you I couldn't speak today. A difference in heart rate of 30 from either laying to sitting or sitting, laying to standing. There we go. Getting it together. Otherwise, you can have people that, like, when you get up, your heart rate should increase. You're changing, your body's adapting, but you'll maintain over 30 beats of a difference between laying and standing. For I think it's like, I don't even know if it's 10 minutes. In the clinic back home, we do, it's probably like 3 minutes, but obviously there's a bunch of things you can also take into account. So like, do they get dizzy, do they get lightheaded, do they get nauseous? There's a bunch of different factors. But there are some people that can't even get to the standing point. So there's people that I've seen in the clinic that they couldn't get above 30 degrees. So they're laying down, they get up to 30 degrees, and their heart rate would skyrocket to like 170. So obviously you can't be like, oh, they don't fit this criteria, they don't have it. Sorry, see you later. But there's a bunch of things you can do. Something that's really, really powerful for these patients are tilt tables. Ellis has one. I want to say most neuro offices that you go to. I haven't been to Lovelace, but I'm gonna maybe assume he has one. Tilt tables are really, really great because you can see where they can handle different degrees until you can get them to stand. So you can do therapies at the degree that they can handle, build up their system to what they can handle, and then continue to go up. And you can also just use the tilt table alone as a therapy. So you can be like, you can't go to 45 degrees, so I'm going to bring you back down, wait till your heart rate stabilizes, and then I'm going to bring you up 5 degrees. So you can use the tilt table alone as a therapy, or you can combine it with gaze state or complex movements or whatever therapies that you want to do with your patient. You compare that with the tilt table to do that temporal summation. Spatial summation. Who's testing?
So POTS is the #1 dysautonomia in
Yeah.
America.
And it's also more common in females. Can anyone guess why? That one. That one. You guys heard him? He said we have to deal with men. That's actually not the right answer, but I will accept that one. It's a little bit, that's a different guess. Kelly and Brian.
I actually don't know.
So it's actually because we have a menstrual cycle. Hey, women. But that blood loss can lead to your autonomics and your sympathetic system just like going haywire. So yeah, fun little, not so fun tidbit for you.
This was the diagnosis of the second to last, not that far, DSD, what's that called, different exam. This was their practical POTS. Actually, I know, it was just dysautonomia.
How do you know that? Did you like see the?
My friend took it, and he that was the
Could you say like briefly what would be the main? I mean, obviously. like,
Yeah,
the heart
you're
rate,
gonna
what
look
would be
for
the-
an increase in heart rate.
with changing
Yeah.
degrees.
Yeah, and a change in blood pressure. Blood pressure, I mean, is gonna drop minimally when you stand up because it has to change, and then it'll go up, and then it'll regulate because of the drop of hormone, and a normal, healthy human. But if it just stays elevated and it's not going back down, they're POTSy. I did a lot of research on POTS a few quarters ago, and it's getting really overdiagnosed. If your patient is passing out, if they're, what's it called, syncopatic, that's not a good word. If they're passing out, that's not POTS. POTS is you don't pass out. That's going to be something a little more complicated. So, but they're calling syncope a part of POTS, and a lot of people disagree with that. Just kind of some of the research there. So that's it for autonomics. Carissa had a question.
Just gonna add on that, just like what Banachi said, there's a lot more diagnoses of POTS that they're putting out there. A lot of things are falling under that. And from the medical world, you're gonna see a lot of patients coming in and they've just put them on increased salt.
Right.
So a lot of them will be drinking water with a ton of salt in it just to try to raise their blood pressure up so they don't pass out and have to work their heart so much harder to get blood up there.
Right.
So that's what you'll see patients coming in with if they've seen other providers.
Yeah, and so that's why it's always important to like do our own exams when patients come in, because you have patients convinced that they have something, and then you just almost have to like teach them that they don't. I was just at Jerome's on Monday, and he's currently doing an intensive with a patient that was told that she has PLS. And the first thing with posterior lateral sclerosis is you lose the sensation posterior, right? You lose the sensation in your toes, and you can't differentiate that. Differentiate. Really good with words tonight, guys. So we laid her down, mapped out her toes. She can go. She doesn't have PLS. Can she walk still? No. But did we get her foot to go from here to here in a matter of 30 minutes? We sure did. Functional neurology is amazing. If you don't shadow someone, go shadow. That's where you learn. Like we can teach the basics, but to learn how to treat someone and see it all in motion, that's when neuro starts to click for you. That's what I'm saying. So I'm going back Friday. I'll let you know if we got her walking. Okay. Any questions? No? Okay. We love you all. Use your sensory recall in midterms next week. Good luck. We'll see half of you. And then